Hello, people. How you doing? Occasionally you come across something that just makes you go, "What? Really? Hello? Is that what I think it is? Oh my god!" So a warrior teacher sent me this morning. Right? You have to listen to this. You have to. I know I don't usually do that, do I? I'm insisting. Bloody listen. You have to listen to it for good's sake, for the love of God. It's attached to the end of this, right? Listen to this because I just can't get past it. If you think you've heard it all, you haven't heard it all. You haven't heard it all. And this type of training is going on everywhere, and somebody's recorded it. So go and have a listen. You'll hear my bit at the end. I'll see you later. Go listen.
I'm Alana Scherer. I also wanted to introduce my colleagues, Dr. Bert Allen and Dr. Chris Bowling, who are also here as content experts. And so we're going to do some breakout sessions and some small group conversations. And feel free, if I'm not available and questions come up or clarification is needed, feel free to ask them. A lot of what we do in adolescent care, in sexual health, in gender care is learning from each other. And so I'm sure that there are people in this room who know a lot more about different topics than I do. So also feel free to stand up and to address questions or to share your own experiences and opinions. The other thing I just wanted to say is I know there's signs all over asking not to video sessions. Please don't video this session. If you see somebody who's videoing the session, I deputize you all to tap on their shoulder and ask them to stop videoing the session. You are welcome to take pictures of the slides. The slides are also in the handouts as well. And it might be helpful if you're able to download the slides to have them available during the small group conversations so that if you need to move back and forth to use any of my slides as references, that those are available to you as well. I have nothing to disclose, and I don't intend to talk about any medications during this session, but it is possible that medications may come up in conversation, so if they do, I will try to address with you if they are FDA approved or not. I wish that we would get in the practice of adding our personal disclosures to slides, because I think that in pediatrics, in really any kind of professional setting, who we are and the power structures that we come from deeply inform how we talk about a subject. So in my personal disclosures, I wanted to say that I'm a queer, cisgender, white, able-bodied woman. I live in the Bay Area, which is unceded Ohlone territory. I do have experience as a mom of gender fabulous kids. However, I will say they're not adolescents, and so I'm often learning from my patients when I talk about best practices and talking about older kids. I have not yet had my own personal experience. I have been caring for gender expansive and transgender kids as a primary care pediatrician and as a gender specialist for over 15 years. I really want to point out that I am a primary care pediatrician. I'm not an adolescent medicine specialist. And I think that's really important because one of my pet peeves about gender care and sexual health is that often as primary care pediatricians, we're sort of like, well, the teen doctors will deal with that. But as we're going to talk about here today is gender and sexual development actually starts quite a bit earlier than adolescence. And so if we wait to refer them to adolescent colleagues, we've really missed the boat in setting up the healthy developmental scaffolding through parents and through caregivers for gender and sexual development. I do not have lived experience as a transgender person, and I'm very happy to give up my microphone at any point. I think that one of the changes that I've seen in medicine over the last 10 years is that some of my transgender patients are going into healthcare now and will hopefully take over my job in a couple of years. And so I would love to hear from more people with lived transgender experience, and I hope that soon we will have the opportunity to do that. Learning objectives, I want you to feel comfortable discussing gender and sexuality using updated language. I want you to learn how to ask open-ended questions about youth identity and sexual behavior. And I want you to identify risk factors for adverse health outcomes and ways to increase resilience. Changes that I want you to make in practice is to ask all adolescents about gender identity and sexual attractions. I want you to be able to provide resources for patients and families supporting healthy gender and sexual development starting at childhood, not in adolescence. And to be able to discuss sexual identities and practices with adolescents using updated language. Okay, so if you're like me and you were lucky enough to have some sort of coverage of LGBT health in medical school, and I went to med school in the early 2000s, What I recall was we had a 1-hour lecture in the first 2 years, and it taught us to do this. Do you have sex with men, women, or both? Right? If you ask your patients that right now, here's what they're wondering. Wait, what are men? What are women? And what does this person mean by sex? So we're going to learn some better strategies for how to ask these questions and what your patients are actually thinking and actually wondering. I'm going to talk about both gender and sexuality today. And gender and sexuality are linked. There's a lot of overlap. However, they are two distinct pathways of human development, and they are two distinct concepts. When we talk about gender, we're talking about who we are. And when we're talking about sexuality, we're talking about who we want to be with or who we love. Okay, so here's a patient that you may have had recently. Hi, I'm Alex. I'm assigned female. I identify as non-binary. I use they, them pronouns, and I present femme. So we're going to unpack that. Show of hands, who's had a patient who said something along those lines to them? Right? And who was like, whoa, 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 slow down. Right? Okay, so that's why you're here. So gender identity has 3 main aspects. The first is assigned sex, and if you've ever had a baby or ever known someone who had a baby, you know that everyone's obsessed with this. And it is usually male or female based on ultrasound images or external genitals or chromosomes. And we know that people can be assigned male or female, and that there's a number of babies who are born every year whose gender is somewhere on the intersex or gender spectrum, who are not clearly male or female. For gender identity, that's our sense of ourself, of whether we're male, we're female, or something else. And we can't actually know someone's gender identity until they're old enough to be able to tell us. So the thinking is that gender identity probably starts to develop around age 2 or 3, could be earlier. But really the earliest that we as observers can know about it is probably around 2 or 3 as well. And gender expression is how we show the world what our gender is. That's our clothing, our external presentation, our pronouns, our names, our style. So for Alex, who told us that they're assigned female, what are they talking about? Which component? Just yell it out.
Sex.
Sex. They identify as non-binary. What is that? Yep. They use they, them pronouns. I think it could be identity or expression. And they present femme. Expression. Okay, so number one question I get when I present this to certain audiences, wait, excuse me. Isn't gender a social construct? And the answer to that is yes and no. Specifically, gender expression is a social construct. As we can see in this photograph here on the right, that's President FDR, taken in 1884. Clearly, gender expression was different culturally in the 1880s than it is now. So gender expression is affected by society, by culture, and it changes over time and place. And kids are very influenced by this reward-punishment system. When kids imitate accepted, quote-unquote, accepted gender behavior, they are rewarded. When kids imitate, quote-unquote, unaccepted or really unexpected gender behavior, they are punished either in overt or in subtle ways. So the important point here is that punishment and reward for gender behavior does not actually change gender identity, but it can change gender expression. If you don't let your kid wear dresses and they never wear dresses, you haven't changed their gender identity. You've only changed their gender expression. This is a very wordy slide, but I find it really helpful to have because I want to make sure we're all on the same page. I'm going to throw out a lot of terms during this talk, and I want to just take a moment and review what they all mean. So you may hear me talk interchangeably about gender diverse, gender expansive, gender creative, or gender variant. And this is a label that is given to children who have a gender identity or a gender expression that differs from what others expect based on their assigned sex. This is a wider umbrella than transgender because this is a label that we may put on other people rather than a way that they're going to self-identify. Transgender is a label that is used by or claimed by an individual whose gender identity does not match the sex that they were assigned at birth. Cisgender is when gender identity matches the sex assigned at or gender assigned at birth. So that's like the opposite of transgender, if you remember your organic chemistry classes from a long time ago. Queer is a really interesting term because if you're above about 55 in this room, you just flinched a little bit when I said that, right? And if you're under 55, you're like, okay, cool. right? So queer was an epithet. It still is, if used in certain contexts, but it is also an example of a term that is now used and owned by the community that self-identifies with it. It is also a term that can refer either to sexual orientation or to gender identity. And if you need to know as a provider what someone means when they say they're queer, you need to ask them, because there is not one definition of what that means about who they are or who they are attracted to. Gender dysphoria is a very specific psychiatric diagnosis, which is a symptom. It's not an identity or a disorder, and it refers to the distress or discomfort when gender identity doesn't match sex. Not all transgender or gender diverse people experience dysphoria, and this was a very specific term that came up basically to have something to put in the DSM, the Diagnostic Statistic Manual, to help with insurance coverage. It replaced gender identity disorder. I don't know what this is or why this is here. I think this is my AD person left here. And it is very likely to be replaced by something else at some point. So don't get too hung up on that exact term. So this is the gender unicorn, which is just a cute graphic way of explaining what I have just explained to you. So I'm going to take you through it. In the unicorn, in their little rainbow brain, is the gender identity. And I like how the gender unicorn displays different aspects of gender as well as sexual orientation as being, I want to say a spectrum, but more of a, what is the right word, when it's like multiple different degrees of intensity as well as a spectrum. I'm not sure what the word is for that, but anyways. So you can have a gender identity that is agender or that you don't feel like a gendered person. You can also have a gender identity that feels fully female. It can also feel fully female and fully male at the same time, which some people term bigender. So someone's gender identity can be simple as male or female, but there are also different layers of complexity that people put into their gender identity. Gender expression so I think actually thinking about gender expression, which is like how we express ourselves to the outside world, might help to explain this, because I see a couple confused faces, right? So I have a gender expression that is not very gendered. You don't know me outside of here, right? But for those of you who do, that makes more sense. I'm someone that doesn't tend to wear a lot of makeup, that doesn't tend to wear a lot of clothing that people would see as gendered at all. My gender expression, do I have a pointer? Okay, my gender expression would be more on the left side of that, not highly gendered. Someone who is very, very feminine in their presentation might be more to the right side of the feminine gender expression. There are also people who mix and have a lot of intense gender expression in both feminine and masculine ways, who have expressions that for both masculine and feminine are toward the right side. For when it comes to sexual orientation, you can have physical attractions and emotional attractions, and they may be to different genders and different intensities to different genders as well. This should not be a surprise to many of us, but a very high percentage of Gen Z, which is the generation just above the generation that we are mostly taking care of, I believe, if I got the dates correct, about 20.8% in 2021 identified as LGBT. So we know these numbers of people who identify as LGBT are increasing over time, and we know that they are absolutely increasing generation by generation. But even more complex is that young people, whether they identify as LGBT or they identify as straight and cisgender, really just don't like the labels of binary gender at all. And so this is an old survey. This was done in 2012 by the Human Rights Campaign that looked at how youth identify with different gender labels. Some of them identified as cisgender or transgender male, transgender female, but at least a third of the ones who identified as something other than cisgender used one of the labels that you can see on the right side of the screen, or their own label, or they said something along those lines of, let me be human, not a gender. The society seems pretty messed up to me about things like this. So kids really don't like to identify as binary gender, and they also don't necessarily like the labels of transgender male or transgender female. And I see a lot of nods. You probably experience this in your own practice. This was part of the same study that asked cisgender kids, so not LGBT kids, on a scale of 1 to 10, how boy or how girl are you? And 28% of boys identified as something other than 0. 47% of girls identified as something other than 10. It's also important to note, and I hate that I just threw this slide in here without a lot of context, because this topic deserves its own 2 or 3 hours of presentation. But there's a very high co-occurrence of autism and gender diversity on both directions. Gender diverse people are more likely to have autism. People with autism are more likely to identify as gender diverse. And we don't know why. I think this is a really positive thing, because we're learning a lot more about neurodiversity and about gender diversity. But sometimes I found that it is used to minimize the gender experience of someone who's on the autism spectrum. So I think just being aware that this exists and this is the reality for many of our patients is a really important thing for you all to know. If you do want to know more, read one of these 2 books that are down here that are both available on Amazon or on more ethical vendors. So what I really want to challenge us all is to think about gender diversity as well as neurodiversity, again another talk, and sexual diversity as natural parts of human diversity. Gender diversity has been around, as well as sexual diversity, since early human history in different cultures and contexts. And actually the idea of the gender binary is very Western. So what if we approach gender and sexuality as expected human experiences, and we transform medical practice to reject the old pathologizing approaches of diagnosing gender dysphoria and feeling like there's something to treat? So gender binary is very much a modern construct. If you look throughout history, there are so many examples in indigenous cultures from around the world, including back in the Old Testament, of gender diversity. There are this really fantastic, on the lower right corner of the slide is this PBS interactive map, and you can click on any one of those little blue dots there, and you can see photos if they exist, because some of these cultures are very ancient, but you can read and learn about all of these different cultures and how they celebrated or just acknowledged the existence of gender diversity, and how a lot of those histories are really erased by colonialist culture. We know that gender diverse people experience adverse health outcomes at rates much higher than cisgender or straight people. But those disparities arise from the impacts of minority stress, not from their identities themselves. We have this cycle where minority stress puts them at higher risk for adverse childhood experiences, leading to social and homophobia and transphobia throughout society, the lack of visible role models, unsupportive home environments, bullying, discrimination. And when you have people of color, when you have people who have disabilities, who are English language learners, or people who have experienced immigration, they are also experiencing the minority stress from those intersectional identities. And so the disparities are much more confounded. That's going to lead to decreased sense of self-worth, self-medication, substance abuse, shame, risk-taking behavior, and suicidality, as well as many other adverse health outcomes. So the intervention, address the minority stress. We need to think of gender and sexual diversity as being part of normal human development, that it's expected, it's celebrated. We're not diagnosing or treating, we're providing support and resources to reduce minority stress, and that we are advocating and empowering all of our children, and really elevating cultural expectations of people around us and of our profession. So parents ask me all the time, is this a phase? And I'm going to take you step by step on how I address that question, because I think it's a very important and valid question. So first of all, this is part of human diversity. There's nothing wrong with your child. Identities shift and change through time. Kids do go through lots of different phases. Adults go through different phases. Most gender diverse kids we know that most do not seek out transgender medical treatment in adolescence and adulthood, because that comes up a lot with parents. It doesn't mean they don't identify as gender diverse or transgender. But kids who are perceived as gender diverse, or as anywhere in the LGBTQ spectrum, are at risk for adverse health outcomes, bullying, and depression now. And so rather than focusing on the future outcomes, we need to meet your kid where they are right now and make sure that they feel seen and they feel loved and they feel supported. And we'll talk about some strategies to help families with that. So one thing to do is to think about your office. So rather than going through all of these in detail, I really want to point out this URL, this very long URL that's right at the bottom here on the right, which is an AAP guide to having an LGBTQ-friendly practice environment. And it goes through all of these things in much more detail than I can really talk about during the hour and a half that I have with you today. And I think it'll probably, just knowing that that resource is out there will probably help. But you want to make sure that your office is set up to support LGBTQ families and kids, starting from when they look at the website to when they call to make the appointment, because you can be as educated about this as you can possibly be, but if the patient doesn't actually make it to you, feeling supported and loved and respected by your practice, they're never going to know that. Practice using pronouns. So, most of us are familiar with he and she as pronouns, right? He is a doctor. I like him. This is his stethoscope. She is a doctor. I like her. This is her stethoscope. Okay, so there's a lot of young people and people my age identifying and using they pronouns these days. And this trips people up, right? It's hard and you can get it. Even if English is not your first language, even if you have been speaking English for your entire life, with a little bit of practice you can get it. One of my young patients told me is, pretend there's a hamster in my pocket and you're talking to both of us. So if you're struggling with they, them pronouns, imagine the hamster, okay? They are a doctor. I like them. This is their stethoscope. Hamster with a stethoscope, think about it, okay? Sometimes people don't want to use pronouns. This is the one that's trickiest for me, actually. And you just use their name instead. Bob is a doctor. I like Bob. This is Bob's stethoscope. When I was in my 20s, Z here and here's and they, them, and zers were more common pronouns. I have not heard them in the Bay Area in probably over a decade. It may be different in different locations, but what I'm hearing mostly now are he, she, they, and not using pronouns or using someone's name instead of pronouns. How to ask about gender. So this is how I ask an older adolescent about gender. My name is Dr. Sherritt. I use she, her pronouns. What pronouns do you use? What name would you like me to call you? Is it okay if I ask you some personal questions that I ask all my patients? I don't actually ask all my patients, I'm going to be real about that, but I should be. And my patients don't need to know that I don't ask everyone about it. Do you think of yourself as male, female, both, neither? I like to talk with my patients about gender identity. Do you know what I mean by that? So if they most of the time now, they're like, yeah, I know what you mean. But if they don't know, I'll explain. Some people might feel like their bodies don't match the gender that they identify with. I might give them an example. This is the same URL I showed you before. So on that same LGBTQ friendly practice, we have multiple very long tables of suggested language that I find very useful. When I'm counseling parents of a younger child, this is something that I do bring up with all of my patients. So as your child grows, we're going to get to learn more about their gender identity. I don't know if you've had this experience, but have you had patients come in and apologize because the kid is not wearing gendered clothing? Like, I've had parents come in and be like, well, we just dressed them in their brother's clothes today. I'm sorry they're not like wearing pink. And I'm like, what? Like, why, right? But, we'll say things like there's no boy or girl colors. It's okay to let them pick what they want to wear. And I think this is part of my anticipatory guidance for all parents. And the most important thing is that your child knows that they're going to be loved and accepted by their caregivers, whatever their interest, hobbies, identities, whatever they love, whoever they love. And to really make sure that that is as explicit as possible from the parent, from the beginning. So I want you, if I can get the video to work, which is always a big question, I want you to watch this video of Dr. Angela Kate Gepfert, who is a pediatrician in Minneapolis. And I love, this is a TEDx talk that they did, and I really love the way, oops.
Do you know what else those kids are learning how to do?
Just watch it.
Do you know what else they love to do? They are learning how to color. And they, in fact, love to color. And what if, when our 2 and 3 and 4 year olds were learning how to color, What if we reached into our pocket and we pulled out 2 crayons, pink and blue, and we said, draw us a picture of who you are. Draw us all who you imagine yourself to be, but we'd like you to do it with just 1 crayon, pink or blue. No, I'm sorry, you actually can't choose both. You have to pick one, pink or blue. Imagine all the pictures we would never see. Imagine all the vividness and color that kids could imagine themselves to be and that they see reflected back to them in the world. Imagine all that we would miss. And now imagine if we handed them this. Imagine if we handed them a box of 64 crayons, and instead of saying, pick one, we said, pick as many as you would like. Show us who you are. Tell us all the stories. Pick one for a while that's your favorite, and then pick another one, and then go back to your original favorite. If you can imagine it, then you can draw it. It is my foundational belief that we all know who we are from a very young age, including the truest expression of our gender identity. And we actually spend most of our lives searching for the words and the tools and the safety.
So it's much longer. I invite you to watch. It's called The Revolutionary Truth About Kids and Gender Identity. And I included that video because I love the way that Dr. Gepford talks about gender diversity and normalizing gender diversity, as well as encouraging just the wide range of expression of it. And it's really informed how I talk with parents. Okay, so what do you do if a patient, specifically an adolescent in this case, discloses to you in the context of a confidential PEDS assessment or with their parents? So if it is in a confidential PEDS assessment, you're going to ensure confidentiality. And there's a little, I get a lot of confusion around this because if you are providing gender affirming care, meaning if you're providing hormones or medications related to gender affirming care, it is typically not covered under confidential care laws. But the conversations that you have as part of your confidential mental health assessment or HEDS assessment of your young people is covered under confidential. I mean, I think state by state, right? But in general, that is something that should be considered confidentially. So you want to make sure that you're ensuring confidentiality. And if you are recording, for example, we use Epic as our EMR. If you are recording names and pronouns in Epic, make sure that you have had a conversation with your young person about who can see that, and that is not going to accidentally out them if the lab calls them by a name that is different from the one that their parents know them. So have a conversation about that with your patient. Thank you for trusting me with this information. And I pause there, which is hard, right? Because that gives me a chance to be like, what am I going to say next? So just pause. I have talked with a lot of providers that panic a little bit in their brain when they get this information, and they immediately start being like, well, I have a clinic I can refer you to, or I can do this, or I can do this, right? But the patient isn't necessarily telling you because they want you to fix it, or they want you to do anything to intervene. So the second thing I usually ask about is I want to know who knows. And if I'm the first person they've told, I'm going to manage that in a very different way than if I'm the last person that they've told. But then what can I do to support you? And there may not be an answer for this. Or some things I might throw out to kids depending on how they're doing is, do you want to meet more frequently so that I'm a safe person that you can talk to on a regular basis? Do you need help talking with your parents? Are there questions that we can help research? Do you need referrals? And then you also want to continue doing your detailed psychosocial screening like you would for any young person. You want to pay special attention to self-injury, depression, disordered eating, and sexual health counseling and screening, which we know are particular areas of disparity for gender diverse youth. Family acceptance saves lives. Some of you were at a talk, so the Family Acceptance Project, whose work I'm about to present, the founder is Caitlin Ryan, who was here yesterday speaking. Amazing. If you've never heard of Family Acceptance Project, go right to their website, which I should have here, but it's in my resource section at the end of my slides. But they have handouts for parents in multiple languages and for particular religious and cultural groups as well. And I find their tools incredibly helpful counseling families. But we know that kids who are in families of higher levels of rejection do poorer than kids who are in families with lower levels of rejection, including they are 8.4 times more likely to have attempted suicide. Time, okay, thanks. Not actually time, just time to stop talking and let you guys talk, so I'm almost at that point. The big takeaway though, is that if you go from high levels of rejection to moderate levels of rejection, that risk is cut in quarters, right? So you don't have to get a highly rejecting family to be super accepting. You have to help them make these tiny little baby steps, and each baby step has exponential power to it. Accepting behaviors include things along the lines of telling them you love them and will be there for them, supporting their gender expression, welcoming their friends and partners, requiring family members to treat them with respect, using their chosen name and pronoun, helping them participate in activities, support groups, and events, connecting them with role models, and standing up for them when they are mistreated. Rejecting behaviors. Some of these are obvious, but not necessarily to the family, and I really want to point that out. Physical and verbal abuse, exclusion from family activities, blocking access to friends for support, blaming the child for discrimination that they face, denigration and ridicule, religious-based condemnation, showing externally to them, showing distress, denial, and shame around their identity, silence and secrecy, pressure to enforce gender conformity. The AAP has some good resources for parents as well. HealthyChildren.org has a couple of articles that you also can share with parents. Okay, so small group. In the tables that you have here, or if you're not in a table, join a table. I have 3 cases. You do not have to get to all the cases. You're going to have about 10-15 minutes for these cases to talk about whatever you want related to them. And I'll leave this slide up, but where it might be helpful for you is if you do have either all the slides up or the LGBT Friendly Practice website up, is to be able to use that for some ideas of language to use. Parents of an 8-year-old who is assigned female, who is adamantly stating, "I'm a boy," and wants to cut hair and change name and pronoun. Parents are asking, is this a phase? What do we do? Case 2, mom of a 14-year-old who's assigned male who's being bullied in school for wearing dresses. Mom says, "I don't know why he insists on dressing that way if it just gets him picked on." Mom says her religion doesn't believe in transgender stuff. The third is a 12-year-old tells you during confidential heads assessment that they identify as non-binary but are afraid to tell their parents. So I'm not asking, I will have you role play for the next session now that I've given that away, please don't leave. But I'm not asking a role play, I more just want to have you to have a conversation with the people at your table about what do you do next. So go ahead.
Anyone want to start? Do you guys do primary care? Yeah. Okay.
I consult. I consult for practices. Yeah, for MSO. I'm an MSO.
Oh, I got you.
So I help consult for practices.
Do you guys deal with this? No. Really? So, okay.
Join your table for a second. I'm Brooklyn.
Hi. Hi.
Don't let me interrupt though. Go ahead.
I deal with this. I mean, I don't deal well.
What region are you in?
This region.
Okay.
So Montgomery County. So I just need to be better at it. So parents of an 8-year-old assigned female is adamantly stating, "I'm a boy." What do you do? What do you want to do? Yes.
So I have a weird story here. I have a twin sister, and when we were probably 4 to 8, we swapped genders. We decided. I wanted a Barbie gun machine, a curtain around my bed for. I thought I would tuck my penis, and she was the opposite. She wanted everything. Our parents let us. I called myself Courtney. She called herself Joey, and for 3 years, my parents were just like, okay, whatever. And then we phased out of it. They supported us. They didn't really, they didn't try to force us with toys or anything. They let me play with my sister's Barbies. They let my sister play with my race cars. But it wasn't an issue. I remember going to, or actually it's more my sister going to my parents saying that she felt like a boy, but there wasn't anything that was necessarily done about it. But after a few years, we phased out of it in a way. And that's why I'm wondering is what could have been done if in a primary care setting, what would have been done differently? Because right now I feel almost that I'm glad there wasn't really any medical intervention or any clinical intervention at that point.
What do y'all think? So
Yeah, no, that's what
that's like a really.
Where'd you grow up?
San Francisco.
San Francisco.
Yeah. Where it's maybe safer.
Yeah.
Yeah.
Well, I had a
Yeah.
similar situation. My niece, so she's 13 now, but several years ago, went to my brother and sister-in-law and told them that she thought she was a boy. And they kind of did what your parents were like. And they were like, okay, do you want to cut your hair? Do you want to dress any differently? Things and stuff, and let her kind of guide that. And now she doesn't feel that way anymore.
So what do you think that means for this 8-year-old, right? That's like, I miss if y'all are clinicians or like, yeah.
Practice.
Yeah. I'm a general pediatrician, right? Yeah. So I bring that lens to it. So I really appreciate the sharing of those experiences and like, how does that translate or not
I think for
to
me,
this
like
kid?
at this age, for me, I kind of just have a conversation with parents about how to feel about that, like kind of see where they're at. I work in a very conservative area, and so sometimes that would be a very big issue for the family to allow the child to explore that or not. Some of my families would be fine with it, but and I think just trying to encourage them to like kind of let it see what it goes, and that you don't have to push it one direction or the other. And things like a haircut is temporary,
Fully reversible intervention, right?
Yeah.
Hair, yeah.
So I'm a general pediatrician from the Bay Area, and my patients fall. So I have most of my sort of gender questioning patients are teens or preteens, but I have one pair of identical twins. Gender assigned at birth was female for both, and one of them, since they were 2, identified as male and asked their immigrant mother for a crew cut and t-shirt and pants and boy underwear, and amazingly this mom was like, fine, okay. So that child is now 6 or 8, and we're just kind of going with it. New name.
I deal with a lot of parents who have difficulty with it, though, especially with boy children. Especially if I ask them, like, boys, what their favorite colors are, would they say pink? Especially if the father is there, they just have a fit. And if their child has that distinction between action figures and dolls, and their child is allowed to play with and have their behaviors. I have a lot of fathers who have more problems with it than mothers do, where I just think the child is just, they're just playing with the toy. The toy is the toy. Until they tell you it's differently, then they're just playing with the toy. They're just enjoying colors, and it's great. All colors are beautiful. It doesn't matter if their favorite is pink, blue, green, black, white, whatever. But then I find more fathers being resistant.
Yeah, I would agree with that too.
What I worry about is like if you treat it as a phase, like if you say the word phase in front of a teenager, I really worry that while the parent, it's really giving the parent a lot of positive meaning.
Yeah.
And phase has a lot of connotation to it. So I try to tell people, things always have been divorced, whether we pay attention to them or not. That's what I worry about, is that I don't want the teenagers to think, oh God, that she's downplaying it because she's saying it's going to be a phase.
Yeah. Well, one thing that I think is really interesting, I wrote down, is, they noted that identities shift and change through time. So why would you do gender-affirming care on adolescents? Right. If that was the main point here, it kind of freaked me out a little bit, but And I want to know, like, yeah, like me. If I had San Francisco, luckily, I mean, not luckily, my parents are from Dallas, but they're, Texans, and they're, and they were smart enough to be like, we're going to let this play it out. But I can see myself in this climate, and I actually have, I have friends who have transgender children, that if I were their children in that circumstance, I do think I would have been put on that pathway in this climate nowadays. And the reason I actually came to this is I'm wondering, some of my practices, obviously they're kind of curious on what to do, but really what it is like, and how easy it is to get on that pathway, and then how hard it is to get off of that pathway once you're directed towards it. So that's when an 8-year-old...
You need to be a little cautious, because the term gender affirming care has this whole...
Oh, yes, you're correct.
Right? And really, it could... And it means medications and surgeries and stuff like that. And kids get sort of on that path, but not... I mean, that's a late adolescent kind of thing when it's not reversible. So when you're talking reversible care, that is it. So when you're talking more like the 14-year-old, you're really trying in their care. And I only know this now because I do it. I don't do weddings. When you're talking about, you're trying to make it less destructive. So wherever they are, like the born females who are getting ready to have their period, and that idea of having their period is really
what if that scares them? And then then you have
you put them on something, but that's, as soon as you take it off, they get their period. I mean, it's just not...
Do you guys want 5 more minutes? No?
Yeah. But I think it's interesting. Just
it was really interesting.
It was interesting that you said, I let her play with my
cars.
And she let me play with her Barbies. I mean, did you guys
We did,
say that
these were our toys? Yeah, these were, because they're our gifts. They were given to us, so now they're mine. But you can play with them, and I can play with those. But then I'm trying to think, though, if this is all, like gender dysphoria, I thought that was a disorder, but I guess it's a symptom. Is that correct?
That's what she said.
Okay, so if gender dysphoria is a mental symptom, what other mental health disorders do we treat this way? And I just I'm having a hard time thinking of going into a pediatric office, and if one of my clients has a patient, I know schizophrenia is really rare in children, but like I'm having a hard time thinking about how clinicians, how you providers would ethically handle some of these cases.
I think you have to deal with the parents for like.
Yeah, that's a huge thing that I.
There's only so many hours in the day, right?
Dependent on the family. There's so many factors to it. There's no one way you do it every single time. Like it depends on the family and where they're at, and if they're, it depends on the environment, just in the general community that you're in.
Yeah.
And how safe it is for that kid to be presenting the way
so
they
worried
are.
about regret.
But I think part of the reason it's so difficult to deal with parents is because of things have become so medicalized.
Right.
Any of us, I think, would be in favor of diverse gender expression. Go for it, right?
Yeah.
But the problem is, if you go down that road now, where might you end up? And so, those fathers that worry about their little boys wearing pink, I think they've got cause to be concerned in the current climate because of the potential path that kid might end up on.
I know. So in Dallas, you're not wrong. There are, when you come to the very conservative and religious households, there are times where, being trans is a lot more accepting than being gay. Trans isn't mentioned in the Bible. It's not mentioned in the Quran. It's not mentioned in any of these religious texts. Homosexuality, you can make the argument it's mentioned or not, depending on the translation, but a lot of these faiths are like, that's the big no-no, that's the sin, like going to hell. So there is a push, I don't want to say push, maybe not the right word, but it's easier to accept their child is a different gender. That's a lot more in line with their religious beliefs than homosexuality is. And so being gay myself, I like starting to see there's like a little bit of erasure on it, and there's, I don't want to say, again, attack's not the right word, but there is gay populations, I feel like, are being affected by this disproportionately. Their options are being almost limited to like, no, it's not that you're gay, you're a female. It's because your gender expression, like we just talked about, we have all different types of gender expression. My gender expression, so like I said earlier, I like some girly things. I like style. I like I like flowers. I like building bouquets. But I also like men. And I know that's not my gender. Everything is, my gender expression should say female for a lot of this, but I'm not. So that's what really freaks me out here when we talk about trans, is I'm really identifying the patients that have gender dysphoria and seeing how do you treat that gender dysphoria, and not just with medical intervention, but let's do the other interventions first and figure out if this gender dysphoria is just a transient thing. Interesting.
Hopefully walk out of here continuing this conversation with. I always find this conference a little bit lonely. I don't know if other people feel the same way, but with the thousands of people who are here, it's hard to really make connections. And so hopefully that was also, in addition to learning about gender and sexuality, I hope that you all feel more socially connected, because we know that also builds you this resilience in medical providers. So I'm not going to ask for a report back on that, because I overheard a lot of really good conversations, and it seems like every table had their own take and really got the topic and the assignment, so thank you. Okay, so moving on to talk about sexual health. Has anyone had a patient that said something along the lines of, I'm pan-romantic and asexual? Yeah. What the heck did they mean? Yeah. Your daughter. Yes, a patient or a child. Okay, so sexual orientation has two main aspects. We've got physical attraction or sexual attraction, and emotional attraction or romantic attraction. It also has these aspects that there is sexual behavior, sexual attraction, and sexual orientation. And these may not match. So, for example, we know that rates of unintended pregnancy are high among girls who identify as lesbians. I was showing these slides to my brother and sister-in-law the other day, and they were like, how? Why? Which is a really legitimate question to ask, right? And I think what it is about, there's a certain level of denial, and there's a certain level of, if you label yourself in a certain way, the messaging isn't always offered and doesn't always get in where it needs to. There are many males who identify as heterosexual who have other male partners. And then many LGBTQ adolescents are not sexually active at all. And I think we always need to check in with our patients before we start immediately counseling them, because the hope is that they're waiting a little bit longer. Okay, so we're probably familiar with terms like gay, bi, and straight. But there are all these terms that are much more common than I'm hearing. Oh, and lesbian, right? But there's all these terms that are much more common than I'm hearing these days that young people are using to define their sexual orientation. So there are the prefixes, right? Yeah, to the left. Those prefixes can be matched with either the word romantic or the word sexual. And then the definition is on the right. So for example, taking the first one, someone who is aromantic does not experience romantic attraction toward anyone. Someone who is asexual does not experience sexual attraction toward anyone. The person in my example was pan-romantic, right? What that means is that they experience romantic attraction toward all genders, or regardless of gender. Someone who is pansexual might experience sexual attraction toward all genders, or regardless of gender. So feel free to take pictures. This picture is not in my slide set, I don't think, because of copyright issues, so feel free to take pictures of that. There's a question in the back.
I'm being really stupid, but What is the difference between romantic and sexual?
So romantic is emotional attraction, and sexual is sexual attraction.
Are you talking physical sexual attraction?
Physical sexual attraction.
Wait, actually, I'm going to double tap. Wait, so physical sexual attraction, as in there's a physiological response?
I think there's overlap. Like,
Okay.
I mean,
Well, I think the point is that this may mean different things to different people, right? And so I'm giving you one definition, but it's useful if a patient's identifying, or your teenage daughter is identifying in that way. It's useful to ask them, what does that mean? Because these definitions are changing, and I don't know if the person who made this slide is necessarily the #1 resource, and I'm definitely not the #1 resource on this. So I'm telling you how I understand this, but not necessarily how your patient understands this, and it's really much more important about how your patient or a young adult child understand.
I have permission from my daughter to explain this whenever it comes up. So if anybody wants to talk about somebody who's asexual but not aromantic, I'm here for you with your website, community by community. All technically bisexual activity. Well, likes the cuddle and has had romantic partners who become problematic. They're not asexual. And, it's like any partner, you negotiate, you discuss, and you're open with it, consenting. And sometimes you do stuff with folks that are okay by you, but if they want it.
So attraction, orientation, and behavior doesn't necessarily match, right? So that's a good example of that. I'm gonna move on. Think about your questions, write them down or something, because I don't want you to forget, but the chances are I'm gonna answer them in the next few slides, okay? Okay, what is the difference between bisexual and pansexual? Who was wondering this? Okay, thank you. So, bi, attraction to two, bi is two genders. Assumes that there are two genders. There are more than two genders, there is infinite genders. So pansexual acknowledges attraction to all genders, not just two genders. So it recognizes the multiplicity of gender. There's also a generational difference with it, but on a technical level, that's the difference. Why are heterosexual, homosexual, and bisexual not particularly helpful terms anymore? Because hetero means attracted to opposite. Opposite what? Opposite genitals, opposite gender. So if you're assigned male, but you identify as female, and you're attracted to females, are you hetero? Are you homo? I don't know, right? Some people might self-identify one way or the other, but I don't know that I have a definition that I would be able to explain. And so we really need new language around this. And thank you to all the adolescents and 20-somethings out there that are constantly coming up with new language and keeping us on our toes so that we don't get dementia. It's really about self-preservation here. Okay. Were there more questions about sexual orientation that you wanted to ask that I didn't address? Go ahead.
Help me understand pan versus poly.
So, okay, so again, this is what the chart says. I don't identify as pan or poly, so I don't know from my own experience, but poly is about attraction toward multiple different genders, but maybe not all genders, right? So maybe someone's attracted more toward the variety of feminine genders, but not masculine genders, or identified more toward non-binary people.
I was going to say, I'm happy to say I do identify as polysexual. I thought I was bisexual, but then I was like, that makes no sense, right? Because I'm a cis man, and if I am bisexual, that means I can only pick women or non-binary people, or, so, but I was like, I'm definitely not pan, because I don't know if I'm really open to everybody in all genders. So it probably was, I only learned about this maybe 3 months ago, and I was like, that's me! I was like, some of them, but not all of them!
Thank you.
Yeah.
There was a question all the way in the back, and then I'll come back to you.
No, I'm good.
No, good.
No,
Okay.
I'll find. Thank you.
Yeah. Oh yeah. I play dumb all the time. Mm-hmm. Yeah. Well, and I'm a dumb middle-aged mom. So like I might look kind of cool, but no, I'm not kidding myself, right? So like I play dumb all the time to my patients, and I'm like, okay, you gotta have to define that for me. I'm from the Reagan era. Yeah. Yeah. All the way in the back.
Got it again, yeah. So, slide after this one, you're talking about heterosexual and homosexual being kind of dated terms, or maybe they're a little bit, we shouldn't use them as much because of, but right here we have hetero and romantic and hetero and homosexual. What I'm wondering is the erasure of homosexuals. If we're talking about this in the trans community, right? Gender expression, I'm gay. So my gender expression, if I like men, that is the gender expression of female. I like flowers. I like dressing nice. I like buying nice things. I like, so a lot of my gender expression is female. What I'm having a hard time with right now, and I would really love to understand, is how that isn't an erasure of a sexual identity.
Yep. Thank you for sharing that, and that comes up in multiple different aspects as well. The other time where I hear that shared is among like butch culture, right? That there are a lot of gay cultures from my generation and the generation ahead of mine, the generation behind mine, that seem less and less compatible with the way that young people identify their sexuality and their gender identity. And I don't have an answer, right? I wouldn't pretend to, but it's real. And so thank you for sharing that. Go ahead.
Told you. I was gobsmacked. I was utterly gobsmacked by what I was seeing. I mean, the fact that at the very beginning, it's don't record. If you see somebody recording, I tap them on the shoulder and tell them to stop. Don't let the cat out of the bag. Don't let people record this. Don't let this get out there. It's a closed session. It's a cult indoctrination session full of absolute nonsense that is a danger to children, women, and gay people. That's what it is. It's utterly extraordinary to me that this is even allowed. But yeah, here we are. Zim, 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 he, her, blah, blah, blah. It's absolute cobblers, and it needs to stop. And this is recent. Tell me what you think in the comments. I'll see. Come and be a warrior teacher. Come and just right, all the usual. I'll catch up with you later. Let me know what you think in the comments.